Any questions, though, before I start? Anything else I've missed, that questions you sent me that I didn't respond to? Okay. Let's start with hormone replacement therapy. So you just got doing that, right? So what did you take away from that presentation? What struck you as you remember or important?
Progesterone on its own, but not estrogen.
Progesterone on its own. What do you
But
mean?
not
What do you mean?
estrogen.
For what?
I don't know.
Okay. Okay.
If a woman's
Estrogen alone causes uterine endometrial
Proliferative.
Yeah.
So unless they don't have a uterus, you want to give estrogen with progesterone.
Okay, so it's always important to know, do they have a uterus or not? If they have a uterus, you have to use progesterone, okay? And then if they have had a hysterectomy, you can use estrogen alone. Okay, good, good, very extremely important point. What else? Come on, you just heard this. Okay, I know you've got more than that. Testosterone can increase your lipids, that's very true. When would we use that? Why are we even talking about that with hormones?
Libido.
Libido, sexual dysfunction. Which women are most likely to benefit from that? Those that have had what? Surgical menopause. So they've had a surgical removal of their ovaries. Okay, who else? What else?
Sooner the better.
The what?
Sooner the better.
Sooner the better. Why do you say that?
She said 40 to 50 years, that's the...
Say it again.
40 to 50 years, that's a peak age.
40 to 50 years, a big age. Okay, so that's when most women are going to probably go through perimenopause and menopause and have symptoms, okay? Did y'all talk about the Women's Health Initiative? Okay, what did you learn about that?
It was anti-hormonal.
Most of the women were older.
That's the study that made people question hormones, right?
Yes.
To not take them.
So it was designed to answer the question. There was mounting evidence that estrogens were helpful in prevention of chronic disease or treatment of chronic disease. So that Women's Health Initiative, which started back in the 90s and went for 13 years, looked at women who were treated with estrogen and progestin, or just estrogen for those women who qualified. And they followed them for active treatment for about 5 to 7 years, and then the long-term follow-up was 13. So they followed them over a decade and a half. So what did they find? What changed? What was surprising and changed? It was a real changer in treatment of women with hormone replacement. So what did they find? It what?
Reduce the risk of cardiovascular.
That's what we thought, but it actually increased. It went up. The increase went up, especially in the first year. It increased by 80%, which was huge. Okay, so what else? So we thought that hormone replacement therapy was preventive. We thought that if we gave women estrogen, they tended to get heart disease about 10 years after men, so let's just keep giving them estrogen. But these women had had breaks in therapy, or had delay in starting of therapy. Okay, what else? So cardiovascular was one. What was the other thing they found went up, increased risk?
Cancer?
Which cancer?
Breast
Cancer.
Primarily breast cancer. Okay. So that was a big, that was also increase, and the women who were diagnosed with cancer had it at advanced stages. Okay. So those two things made, the recommendations came out, and the amount of hormone replacement therapy that was done over the last decade or two has dropped significantly. But now, as always, we always have this big reaction, and then we do sub-analysis, because those researchers have got to keep a job. So I'm being facetious. But it's true. So they're going to sub-analyze all these groups. So then they looked at the younger women, the women who had started this in there, because do people present usually with symptoms in their 60s? Is that the first time they come and go, I'm having hot flashes? No, when are they gonna have?
33.
Well, 40s is early. So average age of menopause is when?
I'm 33.
Average age 52 in this country. Okay, but it can span a long time. It can be late 40s to about 55. Okay. So women, if they're having hot flashes that are moderate to severe, are not going to wait 10 years and come into your office and go, I've been having hot flashes for 10 years. Do something. Okay. So what did they find when they went back and looked at the 50-year-olds? Did you all talk about that? Okay, we'll talk about that. Because that's a difference. That's a difference. So age and timeline make a difference when you're deciding hormone replacement therapy. That's the takeaway. Now the new terms. See, we have to change terms every once in a while just to keep everybody awake and alert. So now we call it menopausal hormone therapy. So hormone replacement therapy, all of those are used interchangeable with practitioners. Okay. Anything else you learned? Y'all have enough coffee this morning? No. Okay. I gave you this one sheet. I saw that the presenter before me also put this in her slide. I think it is really a nice representation. You kind of have to orient yourself. It's a little bit complex, but I think they did a good job. They looked at, they kind of have a set time in the middle where menopause occurs, and then they've got minus years before that and then going forward. So they give you the reproductive, menopausal transition, and then post-menopause. And then underneath that, they look at duration. They look at the principal criteria, which is, they're looking mostly at menstrual cycle length. So women's cycles will stay fairly consistent until they get into that perimenopausal. Then usually they start to get shorter, okay? Because ovulation changes. They'll have variable times of ovulation or they won't ovulate. Then they look at the endocrine part. So they're looking mostly at FSH there. And then you get the symptoms. So I think this is a really good kind of picture of what is going on over a span of years. Symptomatically, what you would see if you measured their FSH and then what their cycles are like. So I would use that as a reference. Okay. Okay. All right. So let's go to page 4 since we've got 2 things to cover. The first 3 pages are pretty much probably a recap of what you have already heard. They're background information for you. I don't take test questions from that, but I assume you understand and know that material. Okay. So replacement therapy, estrogens and progesterone. So let's look at that clinical evidence underneath. So in the past, we thought about prevention, that we could prevent or decrease the risk of cardiovascular disease and osteoporosis. This was well accepted. But current evidence is we don't look at prevention anymore. So we don't put women on estrogens just to assume that that will decrease their risk of cardiovascular disease. However, even though it says prevention, we do use it with osteoporosis, and we'll talk about that in the next hour. So this goes through the Women's Health Initiative. If you look down at the last bullet, what the study found, they found reductions in hip fractures. Okay, yay, that's why we can still use estrogens to decrease or to help in the prevention of osteoporosis. However, the caveat is that it's not recommended that you use it only for that reason. If you're using it for other reasons to treat vasomotor symptoms or genital urinary symptoms, then also kind of using that plus, it's like that extra scoop of ice cream on top, then that is acceptable. Increase in breast cancer is listed there, 24% increase, but the hazard ratio is 1.24. So what is a hazard ratio?
So if a study's set up and you're looking at any particular time during the setup of the study, what the possible, I think, mortality would be, or?
That's possible, that's possible. Anything else? Hazard ratios are a comparison. So they're usually comparing a treatment versus a control. And they're naming an event or a progression, or that mortality could be an event. So they're going to look at some event. So here, we were talking about breast cancer. So they're going to look at women who were treated with hormone replacement therapy versus those that were not. Okay? So the hazard comes, is there a hazard to one or the other? Is there a hazard to treating, associated with the treatment? Here it was, we're using estrogens plus a progesterone or that alone. Or in the controls, because we did not use that, did they have an increase in this event we call breast cancer? Okay, so if it has a hazard ratio, so we're always comparing treatment to control, hazard ratio is 1.24, what does that mean?
That they happen more in the
treatment
treatment
than the
group.
control person.
Say that again?
Is it like the treatment has 100% and the other person, the other side's 20%?
Not that extreme. So it tells you that the treatment is more an event is more likely to occur in the treatment than versus control. Okay. The higher this number is above 1, then the more likely the event is to occur in treatment. Now, if it had been 0.3, then treatment very unlikely to cause it, control very highly likely to see that event. Do you follow that?
Yes.
Okay. So, the higher the hazard, the higher associated with treatment. Always the treatment side is what we're looking at. Okay, colon cancer decreased the risk. But if they were found at a more advanced stage. And why that is, I have no idea. Now the next three are what, so the breast cancer got people's attention, and also cardiovascular disease, stroke, and clot risk. Okay. So there, the risk went way up in the first year. But overall, if you look at all the years the women were on it, it was 5 to 7 years, it was about 18%. Okay. But look at what it translates into. 8 events per 10,000 person years. Still fairly low. But if you're one of those 8, it means something, right? Okay. Hazard ratio 1.23, so higher with treatment. Okay. Stroke was a 31% increase. DVTs, PEs were pretty high, double. So hazard ratio 2.06. Okay. So that's what made the recommendation to don't just put everybody on it. And don't do it because you think you're going to prevent these things. I think people always knew that the cancer risk because we were using a prolonged estrogen was a risk. This put a number to it. But cardiovascular, I think, surprised folks. Okay. So, can I push it? Let me check. I didn't put it in here. So what they did is they went back and they've looked now at the 50 to 59 because people start earlier than 63. So now it's timeline. It's under 60 and they don't have any contraindications to estrogen use. And they're less than 10 years out from menopause. Those people have low risk for events. So if they have low cardiovascular risk, low breast cancer risk, they're less than 10 years out, and they're under 60, then the recommendation is, if they're symptomatic, treat them. Mostly this is going to go to vasomotor symptoms, not the GU, because that we can use a very low topical, and risk is very low with that. So this is mostly vasomotor. Okay. This is an important distinction. So when Thatcher said sooner is better is when people start having symptoms, and usually they're gonna have them within the first year of going through menopause. Menopause means what?
No.
1 year, I hear. What else?
Menstrual.
No cycle for 1 year. Okay, then you're postmenopausal. Okay. So if women are, once they get through that, most of them are gonna have symptoms. Almost all women have symptoms. Can be very mild, they put up with it. So the threshold is more dependent on the person. But some of these are very severe. Did you talk about severity? What does that look like? What would a severe vasomotor symptoms look like?
Waking up in the middle of the night, for instance.
Waking up in the middle of the night. I've had women tell me about having to get up and change bed sheets, change their bed clothes. So some of them are just annoying. They may be 10, and most women have more than one in a day. So it's annoying. They can't get comfortable. So you see the picture I put in there of the woman who's standing in front of the fan. So those would be more severe. Mild, some people are just gonna, no big deal. And they're momentary, but if you've got 10 to 20 a day, it might be enough. I saw the cartoons she put in there, they were pretty good. Okay, so if you go to the top of page 5, this is an algorithm for helping you think through. So if a woman comes in and she's interested in hormone replacement therapy, she's under 60 and she's less than 10 years from menopause, then treat her. If she's beyond that, then you're going to have to look at the woman herself. Maybe she's had an interruption in therapy. Maybe something has happened to make those worse, or you need to think about other causes for her symptoms. So the first thing you're going to do, like is where we always start, is here's what I can use, but who should not be on it. So contraindications, always first, really important in here. So here, unexplained vaginal bleeding. Duh, right? If we give them estrogen and she's got a cancer or hyperplasia in there or polyp that's bleeding, then we'll just make it worse and cover it up. Cardiovascular, what's their risk? Have they had a stroke? Okay, you're getting into the timeline where women could be in that category, especially diabetic women, hypertensive women, women who smoked. So stroke, if they've had, or TIAs, they've had an MI, they've had a DVT or a PE, we're not going to put them on this. We're going to think about other things, and there's other drugs that we can consider. The SSRIs or the SNRIs, these are not the greatest because they have cardiovascular effects, but you can also look at gabapentin. We'll talk about it in particular. Clonidine is down the list, but it is one that could be considered. Breast cancer or endometrial cancer, those the oncologist is going to have to make those calls, especially if we're looking at GU. Some of these other drugs we could use in women who are on treatment for breast cancer or preventative, like tamoxifen. Active liver disease, we depend on the liver to get rid of these drugs. If they can't metabolize it, then their exposure is much greater. Okay, so those are absolute contraindications. Do not use those drugs in those women. Now, use with caution in women who have diabetes. High triglycerides, estrogens will just force them up. So it depends on how high the triglycerides. If they're running 15 to 2,000 triglycerides, I would pay attention. If they're running 300s, I'm not that worried. Okay, ain't gonna go up that high. Active gallbladder disease. Why is that? We talked about. So you're seeing those same contraindications come up that we talked about with the contraceptives, right? Okay, we'll just make it worse. Estrogens will precipitate out and increase the risk of gallstones. High breast or endometrial cancer risk. Or migraine with aura. Here it is, Audrey. Okay, so we've done that. If we decide that we are not going to use those estrogen products, then we go over to the others. Next then is we think about, because of the Women's Health Initiative, what is their cardiovascular risk? What is their breast cancer risk? If it is low or acceptable, then you can move down into these products. Then you're going to look at, am I treating vasomotor or am I treating GU, vaginal atrophy and GU complaints? Because if they are one or the other, we're going to treat them differently. If it's GU with vaginal atrophy, we're going to use a topical product. And the risk there is very low. If we're dealing with vasomotor, then we're going to use usually a systemic product, either tablets or transdermal. Okay. So then we're going to reassess them on a periodic basis. You see all kinds of people haven't quite landed as to what to do. You'll see recommendations assessed yearly. Okay, that can be reasonable. You'll see them on a yearly basis. Don't use more than 5 years. Well, how long do women have symptoms? Average. 7 years. So what's the 5-year? And some women go 10 years and longer. So it needs to be individualized. I think always keeping in your mind, are you at the point where we could take you off? This is vasomotor only. The GU, you have to treat long term. It just doesn't go away. You got to re-epithelialize the bladder and the GU tract and the vagina to get the symptoms to a reasonable level. Okay. All right. Have you heard anything that was different from what you heard last hour? Okay, great. All right, next page. So hormone therapy. In that very first, intact uterus, got to use progestin. Now, we're going to get down to some points, it's like, okay, what if we're just using a vaginal cream? Do we do it then? So we'll talk about that. But if they're using systemic therapy and they've got a uterus, you've got to use a progestin. Okay, so think treatment. When you think about hormonal replacement, think treatment. You're not preventing. The only prevention will come in small doses with osteoporosis. There's lots of different estrogen preps. I've given you a table a couple of pages over, and I've given you the different products. These are examples of them and what they look like. What have I told you when there's lots of dosage forms? It's a huge market, and there's lots of niches. So estrogens come oral, they come as transdermal products, they have topical gels, lotions, sprays, we have intravaginal creams, we have intravaginal tablets, and intravaginal rings. So let's look at the, one other is that you will see that estrogens are referred to as conjugated or they're referred to as micronized, okay? So the conjugated are the old ones. They're mostly estrone, but there's all types of estrogens in there. They're conjugated because early on they collected them from urine from mares, okay? And to get rid of estrogens, you got to conjugate them, okay? So the liver, remember, that's one of the steps of metabolism is we conjugate, we put these additions onto drugs, it makes it more polar, and bingo, the kidney can get rid of it, okay? So that's why they're called conjugated estrogens. Been around a long time, they're cheap, probably the cheapest of the ones out there. The micronized are taking estradiol, 17-beta estradiol, and it's the same estradiol your ovaries make, not Fong or Paul or Ron's, but that's what your ovaries make. And they micronize them because if they don't, they won't get absorbed. So they make them really small, and then they are absorbed through the lymphatic system just like the fats are. Go back and look at those, the triglyceride and fat absorption out of cardiovascular. We talked about that. We talked about the lymphatic system and how the fats go through that. So those estrogens will be absorbed through that system, and they'll get to your gut eventually. So all of the estradiol that we give is micronized, whether it's in a tablet or it's in a patch or it's in a cream. And that makes a difference. Okay, so the oral estrogens, There's a difference. And so the oral estrogens are less expensive. They've been around a long time. People are comfortable with them. But they are different from the micronized estradiol in terms of their effects on cardiovascular risk, for one. So these are, they have the greatest effect on the liver. So anything the liver makes in terms of proteins, these products will increase that production. So you see in that second bullet things that happen. So thyroid binding globulin goes up. Corticosteroid binding globulin goes up, your sex hormone binding globulin goes up, triglycerides go up, HDL, clotting factors. So lots of things are influenced by that. So you have to keep it in mind. You don't see that with transdermal. Transdermal, we can get around that liver. So transdermal is preferred because of that reason. All estrogens are equally effective. Doesn't matter if you use the micronized estradiol or if you use the conjugated. They're all effective. Okay, under that next section, let's see if there's anything. I've told you all that. So go down to transdermal. So transdermal is preferred because there's a lower risk of clot. There's also less effect on the liver. So all those things I just told you about the liver, those are minimal with transdermal. Now, some women may not want to use them. They are more expensive. They've used the oral old conjugated, like Premarin in the past. That's what they want to stick with. As long as there's no reason to move them off, it's still acceptable. But transdermal is preferred. Okay. Topicals. So topicals are gels, come as gels and sprays, and you'll see those in the table. They need to be, so a couple of things about them. One is that they need to be given the same time each day. So we're relying on skin. The gel Dibagel is usually put on the legs, both legs, have to let it dry. It has alcohol in it, so it's flammable, so it's like, don't get near. Has Dr. Britton ever told you about his rum 151? Have you ever bought that stuff? Oh my gosh. So he has this drink he likes called Nicodemus. Has he told you about those? You got to ask him about his Nicodemus. So this stuff requires like 2 or 3 rums. So we always go to this little dive place that has the best food. That's where I told you I eat those livers? Yeah. Okay. So they have this drink called Nicodemus, and they'll only let you order 2. They won't let you do any more. And I told you the police camp on either side, and they get you for drunk driving? Yeah. So you make it with this rum 151. So we go to the they call them ABC stores in Alabama. So we go to the ABC store and we buy the rum, and as we're checking out, the woman says, you know not to get near fire when you use this. I'm like, what? But on the bottle it says, don't get near an open flame because it's such a high alcohol content. Is what, yeah, that's what they set on fire, the shots, yeah. So that was just a little aside. I will not test you on that. Okay. Please do. Okay, transdermal spray is the Eva Mist. This one is a meter dose pump. If you look over a couple of pages, you'll see it on the second page. Right up here. So it's kind of got a round, big applicator that you put on your forearm, and you pump it, and it will administer it. You can do up to 3 pumps on the forearm. So some of the downsides of this is that you can't be around kids, or you can't pick up kids with a exposed arm. So like grandmothers who are taking care of young kids, they've even reported these in animals that have been held up against them, is they'll absorb enough estrogen through the skin that they will get nipple enlargements, discharge. So that's a downside. So if they're going to be around like kids, I'll get you, then just wearing clothing over it but it's just one of the downsides.
Like
Yes.
they can't touch kids ever, or they just have to wait till it dries, or?
They don't need to have kids in skin contact ever.
Oh.
So they just need to wear a long sleeve. Okay, so those are the spray. So if you don't want to use a cream, you don't want to take a tablet, it's just another option. Vaginal estrogens are usually used to treat vaginal atrophy. And we usually use very low doses because the systemic absorption is very low out of these products. However, you can use high dose in order to treat vasomotor as well. If you're going to use the high dose, you'd have to use a progestin with it. So all of those require a progestin. Now, the very low dose, we'll talk about that. There is some recommendations that with very low dose products you don't have to, but I'll get to that in just a minute. Dose equivalents, you don't have to memorize these. I'm just showing you that there is language so that you understand what those mean. So standard dose is kind of what we've always used in the past. Low dose is half the standard dose, and I've given you some examples there. And then ultra low dose, one of the estrogen patches, Menopausal, which is indicated just for prevention of osteoporosis, is an ultra low dose. Very, very low doses of either the oral or the cream of the beta estradiol are ultra low dose. Usually with ultra low dose, you don't have to, it's not recommended to use a progestin. Okay, so that's kind of the estrogen products. In that table, I have given you, what I want you to know is I've given you an example. I want you to know the different routes, and I want you to be able to match up a product with a route. Under those transdermal patches, there are a ton of them. I just gave you the Vaginal dot as one of them. Premarin is the oldest of the conjugated estrogens around. Been around forever, probably 50, 60 years. Estrase is the beta, 17 beta estradiol. The patch is always going to be an estradiol. Well, not always, but the one I gave you is. The Divagel is the one I told you to put on the legs. On the next page is that spray, the Eva Mist. And then the intravaginal, there's three. The ring, Estring is one of them. The little tablet in that applicator is Vagifem. And then the cream is Estrase. Those are all 7 beta estradiols. Okay, questions about those?
I just have a quick question to clarify.
Yeah.
So just to be clear, you said always use a progestin unless it's an ultra or low dose vaginal?
Yeah, and when we get to those, I'll go through that again.
Okay.
Most conservative would be always use a progestin. Okay. All right. What did she tell you? What did the physician before me tell you about using progestins?
You said unless they don't have uterus.
Did she make a distinction with the very low dose products?
No,
Okay.
not that I know.
Okay, another product that has been on the market for just a few years is Duavie, and it is a conjugated estrogen plus what we call a SERM, vasodoxaphene. So this is a product that is indicated for vasomotor. It's at the bottom of my page 7. It's indicated for for the vasomotor symptoms. It has estrogenic effects on the bone, so it builds up bone. It's an antagonist on the endometrium, neutral on the breast. So if you have women who have a lot of breast symptoms from using estrogen, this would be a product you could use instead. You have women who are higher risk for breast cancer, this would be one to consider. The downside is it increases the risk of clots. But one to keep in mind. All right, skip over a couple of pages to top of 10. Progestins. There are a million ways from Sunday to give progestins. I'm just going to give you a simplified approach. So there's the most common use and there's the preferred use. Okay, most common is the medroxyprogesterone. It's been around forever, so a lot of people use it, they're comfortable with it. It can be taken daily or it can be given in cycles. Some people give it for the last 10 days of a cycle, or, I mean, there's many ways. So just know that cyclically means that they're not taking it every day and there's a pattern to the cycle. The downside of it is that it increases the risk of breast cancer and cardiovascular disease. But I'm telling you it's the most common because it's been around forever. Okay? One that is preferred and is taking its place is the natural progesterone. Prometrium is one of the brand names. So it is a micronized progesterone. Comes in two strengths, 100 milligrams a day, or 100 milligrams and 200 milligrams. It can be given 3 times a week. So Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday. At the higher doses. So as long as you get 12 days in a month, then that is protective. And then some will use the 100 on a daily basis. It does not seem to increase the risk of breast cancer or cardiovascular disease. That's why it's becoming preferred. Did you all talk about those, the difference? Just talked about progestins in general? Okay. I did see that she put on her slides about Mirena use, using an IUD. That is an off-label and not approved, and I know insurance will not cover it. And it can be fairly expensive, but it might be a very good option for women who are willing to pay out of pocket for it. Because that will last for 5 years. They're probably going to be taking the estrogen for 5 years. There is no studies to tell you that that is going to do what you think it's going to do, but it's reasonable given the effects of progestin to assume that it will also be protective. Okay. All right. Questions up to this point? Okay, management, so where do you start? So estrogen is the gold standard, so you start with there and you rule it out. So contraindications ruled out, breast cancer, cardiovascular risk, rule it in or out. And then go to other options if you have to. Usually you're going to be looking at women who are moderate to severe. So women who have mild hot flashes that tolerate it, there's no reason to treat. If they're not seeking treatment, there is no reason to treat. You know about the intact uterus, whether to use a progestin or not. Start with the transdermal. So the recommendation is start with the transdermal 17-beta estradiol because of the benefits, because of the decreased cardiovascular risk, decreased effects on the liver. You could also use an oral if women wanted to. Again, you can use the 17-beta estradiol. Estrase is one of them. You'll see the doses recommended at 1 or 2, but you can start as low as 0.5. You're going to start with the lowest transdermal, lowest oral dose. Use it for a month, see what the effects are. If the woman's still having hot flashes but they're tolerable, leave her at that dose. If she's still complaining, you can go up. After a month, you can go up to the next dosing interval. Okay. Most women are going to do well at those lower to mid-range dose. Few women are going to have so severe that you'll have to do a higher dose. Estrogens are given continuously. Now a patch, you think it's twice a week is the patch, but it's continuous release of estrogen. Okay. Breast soreness tenderness is usually the main complaint. I put down there about how long to treat. That's going to be based on the woman's response and her risk. When you do get to the point where you want to try them off of it, it's recommended that you taper. Anytime you take these products off, their symptoms will resume. They may not be as frequent, but they will still come back. So it's recommended that you do a slow taper to help manage the side effects, not the side effects, but the occurrence. And if you're going to do that, taper the progestin with it. Just remember, you've got another drug hanging out there that you're using for a different reason. Okay, questions about those? All right, let's go on to non-hormonal therapy. So if you can't, or a woman does not want to use an estrogen, then there are non-hormonal therapies. So you can use SSRIs or SNRIs. Paroxetine does have an FDA approval for the use of hot flashes. However, some women, like, they're on tamoxifen, they cannot use it, or what's the problem with paroxetine? Anything you can remember? Weight gain's one.
Yeah, that's one that had all the,
Citalopram is the QT prolongation. Okay, so just keep those in mind, the cardiovascular effects if you're worried about it. So those can be used. Gabapentin can also be used. And here we usually start with a low dose. The good thing about gabapentin is that you can give it at night. If women, and a lot of women have night sweats, symptoms at night that wake them up, they can sleep through them, or if they do wake up, they more easily go back to sleep. So usually starting with 100 milligrams at night and increasing it every 3 or 4 days to effect. Up to as much as 900 milligrams a day has been shown to be effective. Pregabalin or clonidine could also be used as alternatives. Women with breast cancer, so chemotherapy, you take out their ovaries, you put them on tamoxifen, all of those will increase their risk of hot flashes. So the drug of choice here is citalopram, because paroxetine interferes with the transformation of tamoxifen as a pre-drug, you can't convert it. So keep that in mind, that's a big drug interaction there to remember. They could also be used on gabapentin, though, would be an alternative. Non-prescription therapies, I'm not going to say much about that on that page because I know she addressed it in her slides. On the next page, page 12, lots of herbals out there, lots of promotion of natural estrogens. Okay, so I'm telling you, none of them have any long-term safety or efficacy data. I wouldn't recommend any of them. However, if women are going to use them, they need to have some sense that this is an active drug that can cause major problems. So I would screen them for the same things that we have talked about and caution them about that use. Unsupervised use may not be a good way to say it. Herbal products, same thing. Bioidenticals. I know she talked about in one of her slides, I know she talked about, did y'all talk about bioidenticals? Okay, so what was the takeaway?
the same
Not
hormone.
regulated.
It's not FDA approved.
Okay, so bioidenticals mean they are not the same, but they do the same thing, okay? So they are structurally different, but they in the end will do the same. So the FDA approves bioidenticals, and we have those available. Bioidenticals are often, what I put down here in the lay literature, refer to those products that are compounded by compounding pharmacies. And they will make progesterone suppositories, and they'll change them based on a woman's response. And some women feel like that's more natural. So I would never recommend those because they are the variability in amount and the reproducibility is not going to be as good as what you're going to get out of a FDA approved product. She did say one thing is that those groups are not regulated, which is not true. Compounding pharmacies are regulated. And they have to meet certain standards. You can't, and all pharmacists are trained in that way to be able to compound. So I would take issue with her there, but I don't take issue with the fact that the variability is probably greater.
She did say that just the compounded products are not regulated by the FDA, that she would work with compounded pharmacies and not.
There you go, that's a good
She
thing.
did say that.
Are they, I think two maybe different, they're not federally regulated, are they state regulated, like the actual pharmacy itself? they're not under federal regulation, right? Or under state regulation. I don't know, I just was wondering that in my mind.
I think there are federal, you know, the big problem that came with on the East Coast when they produced those injectables that had contamination, I do believe there's federal regulations. I can't tell you.
Yeah, I can't remember. And I know we had issues with that in orthopedics with topical steroids.
Yeah.
Too, with there being some skirting around the.
Yeah, well, anybody can be unethical.
Right.
Pharmacists as well as physicians and everybody else in between, so.
Yeah.
That is good. I think that is good that if you work with a group. Now, I'll tell you, most pharmacies, a lot of chains, are not going to do compounding. It is so time consuming, and you have to set up a special room, and you've got to order in bulk products that are USP approved or meet USP standards. So it is not a cheap thing to do. A lot of pharmacists do it because they like it. I love doing compounding, but most people are not going to do it. Most people are going to do it are doing it because they really like that or they're using that as a service. So it's usually going to be independent pharmacies that do that, but they have to meet standards. And most of them go through extra training to do that. Probably one of the best is in Midwest City, Lassiter's. Probably one of the best in town. If you work in this city and you ever have a problem with getting a drug down a person, call them because they're probably the best and have been around the longest. So there's all kinds of ways to formulate drugs to help get them down or get them used. Okay, summary I'm not going to go through because I'm running out of time. So I'm going to finish up this because I can do this pretty quickly. And then we'll take a break. If you look on page 12 under adverse effects, that's really the only place I've given you more detail. So estrogens, look back at what I gave you in contraception. The same kinds of symptoms that I told you under combination products are going to go here as well. So nausea, bloating, headache, breast tenderness, edema. What did I tell you? Pregnancy. Higher dose estrogens, similar to pregnancy type complaints. Progestins, so here's the androgenic part. Increased appetite, weight gain, fatigue, hypomenorrhea, acne, oily. See the androgen effect show up there? Hair loss, hirsutism, depression, irritability, headaches. So if you learn it for one set, it will hit all the different times we talk about it. With the transdermal, it's always going to be site application. So they get a rash, they get irritation from the site. So again, with any transdermal products, you always want them to move it around if it's a patch. Now we don't do that with that spray that I talked about, nor the Divagel. Those are applied to the same place every day. Okay, questions to this point on vasomotor. Okay, let's talk about vaginal atrophy. The new term that came out in the new guidelines, they got a new term, genitourinary syndrome of menopause. Okay, so people use vaginal atrophy, vulvovaginal atrophy, urogenital atrophy, atrophic vaginitis is a very common term. So the problem here is that you have a loss, if you look on that, one of the first pages, back on page 3. So you have a lot of loose loss of epithelium. So one of the things we try to do is re-epithelialize those mucous membranes to decrease symptoms. So vaginal dryness and painful intercourse or dyspareunia are common complaints. But it can also be GU complaints. Women may show up with symptoms of a UTA. Hi, I have got to go frequently. After I go, it burns. You get a urine and it's normal. And it's like the specific gravity is really low. It's like, have you been drinking a lot of water? Yes, because I'm trying to decrease those symptoms. And it's in a postmenopausal woman, think atrophic vaginitis. Okay, so they can have very similar symptoms. So first line, if their symptoms are mild, then use a vaginal moisturizer. There's several of them written down there, given to you. Replens, I'll use that as an example. They can buy it over the counter. It's usually back in the women's products, by the pads and the other women-specific products. That is one that is can be inserted every 3 days. It's a gel. It's got an applicator. They insert it, and it'll stay in place for 3 days. So that's a nice one. But any of these others, KY Jelly, Silk E, these are just different brands. Vagisil, next one also. These can be used alone. If they take care of the symptoms, great. You don't have to expose them to a drug. They can also be used in combination with estrogen products as well to give further relief. For women who have lots of dryness and that makes intercourse painful, then they can use vaginal lubricants. So KY Jelly again is common. Astroglide is another one, very similar product. So mild. Women who have significant dryness, then they need an estrogen for relief. Here we use intravaginal products. So the oral agents are not as good at treating these. So we've got, and we like it because if we're just going to use a vaginal estrogen product, the systemic absorption is low, really low. Especially if we use the low dose, the recommendation if you're using the low dose for certain products, then they don't recommend. It isn't that they don't recommend a progestin, they just say the progestin isn't required. So here we've got, there's tablets, vaginal tablets, called Vagifem. They are usually given daily for 2 weeks, and so it's a tablet inserted by an applicator for 2 weeks, and then they'll back off the dose. So this is with the creams as well. Usually we will treat them for 1 to 2 weeks, get the symptoms under control, and then we'll back off to anywhere from 1 to 3 times a week, whatever controls symptoms, lowest amount. Once you get them reepithelialized, then symptoms usually go away or get minimal, and you can maintain them with very low doses. Often, I will tell you that the Vagifem is a low dose. It's 10 micrograms, I think. It often is not enough to get a woman who has severe symptoms under control. So probably the best, this isn't written down, I'm just telling you, probably the best if you've got a woman who's got fairly significant symptoms is use the creams. They spread better, they'll just give better symptom control. Then you can back off or you can convert them. There's another one called the ring, Estring, on the next page, I think I put it down. Estring is a fairly good-sized ring that you insert intravaginally, leave for 90 days, and it gives a small amount. Again, for a woman who has moderate to severe symptoms, it will not be enough to get her under control. So use the creams to get them under control, symptoms abated, then you could switch them to tablets or to the ring. Okay. Questions about those? So 3 options: cream, tablets, ring. Probably cream the best acutely and then switch them over. They can stay on the cream and do it 1 to 3 times a week, or they can wear the ring all the time, or the tablet a couple times a week. Estrogen vaginal creams come as conjugated estrogen, the old Premarin, or the estrase, the estradiol cream. Either one is fine. You probably are going to get more absorption out of those conjugated estrogens. There you should use a progestin. Under the estradiol, it's 100 to 400 micrograms of estradiol. Again, you see the 2 to 4 grams of cream for 1 to 2 weeks daily, and then switch them over to, you titrate them down to whatever keeps them asymptomatic. Use of a progestin. So the manufacturer recommends if you're using Estring or Vagifem that a progestin is not required. With the creams, there's variability in absorption that women will absorb, so there the most conservative approach would be use a progestin. Questions about those? Those are your mainstays. So 2 other products that are on the market: Pasterone, which is brand new. is a vaginal insert. It's an alternative to the low-dose estrogens. It's actually converted, once it's inserted, to DHEA. It's converted to estrogen and androgens. For women who don't have a contraindication to estrogens and they want to avoid estrogens, I don't know where this one's going to fit, but it's an alternative out there. It wouldn't be first line. Osphena is very specific. It is a product that works on the estrogen receptors in the vagina, and it's only indicated for dyspareunia. Most common side effect is hot flashes, so I think you're just going to find a narrow group of women who, and again, as women get older, this vaginal atrophy will never go away. Their symptoms will never go away, so they will always require some type of estrogen to keep them asymptomatic. So if they don't want to use an estrogen, this might be one to consider. For women who have breast cancer and symptoms of vaginal atrophy, you can start with moisturizers, but that should be handled by their oncologist. Don't use estrogens in them without consultation. The last are the androgens. Very few women are going to fall into this category. Again, it's mostly women who have surgical menopause or have a true androgen deficiency. So that's the narrow indication for them to improve sexual activity, loss of libido. So the formulations, it should always be given with an estrogen, so star that. So there are products that are available. Estrotest and Centest are combination products. Oral methyltestosterone is the androgen that we use on a daily basis. And then you're going to look for those hyperandrogenic side effects would be the concern. The biggest concern I would see is adverse lipid effects, especially in women who have a high risk of cardiovascular disease. And if they already have androgenic problems like hirsutism or alopecia related to androgens, severe acne, all of these will be made worse by these. Questions? Anything you've heard that was a contraindication to what you heard last hour? Okay. All right, let's take a break and we'll come back and